Hi everyone, I'm Dr. Preeti Sharma, your pathology and microbiology faculty at PrepLadder. And today we have an integrated session, which is a derma path integration. And of course, we have Khushbu ma'am with us, who will be giving us all the information about dermatology section. And the topic that we've decided for today is something which is very important across all entrance exams, be it FMG, NEET PG, or the upcoming INI-CET as well. And that is the Immunobullous disorders. So, ma'am, this definitely takes me back also to my residency days because this is something where we had to talk to the dermatologists a lot. A lot of skin biopsies used to come to us, and then we were very new in that era of applying immunofluorescence. And I think now, although it's just a routine in every lab, but it gets a lot of questions also. So I think we've picked up a topic which is very high yielding, and I think we should start right away. So over to you, ma'am.
So hello everyone and welcome to this integrated session, and this is, I believe, the best topic for derma path integration. This is a very important topic which comes every time in the exam, and most of the time the question that you get has an integrated derma and pathology to it. So there would be some pathology options, or in the question there would be something in the pathology which would help you clinch the diagnosis. So now the purpose of today's session is to give you quick crisp points which will help you differentiate between different immunobullous disorders. So when we have immunobullous disorders, broadly in your mind, when you look at the question, you have to classify it into two broad categories, whether it is intraepidermal or subepidermal. So when we have an intraepidermal disorder, that means my target antigen would be somewhere in the epidermis, and so the split that is happening would be also in the epidermis. So it would be either a subcorneal split or a suprabasal split that I am looking at. Whereas if it is a subepidermal disorder, that means my target antigen is targeting dermoepidermal junction, and so the split would be subepidermal. Now, how do you differentiate between the two broad categories? An intraepidermal lesion would present always with flaccid lesions. By flaccid, we mean something which is like an old grape, or a balloon which is almost very flaccid or floppy. So flaccid blisters, if you see in the question, is pointing directly towards intraepidermal disorders. Whereas if you have tense blisters, think of subepidermal disorders, because here the target antigen is at the dermoepidermal junction. So the roof of the blister is formed by whole of epidermis. So here my bulla is tense. So intraepidermal flaccid, subepidermal tense. Then mucosal involvement is very important in intraepidermal disorders, especially in pemphigus vulgaris group of disorders. Whereas in subepidermal disorders, mucosal involvement is not so common. So if they are specifically mentioning that there are oral erosions, there are mucosal involvement, think of pemphigus vulgaris, which is an intraepidermal disorders. Then next point, Nikolski sign positive. So Nikolski sign positive would mean again an intraepidermal disorders, because just by a shearing force, you're able to form a bulla and an erosion. That means your split is superficial. So flaccid lesions, mucosal lesions being present, Nikolski sign being present, these are some clinical cues which help you differentiate between these two broad category of disorders. Obviously, we'll be discussing about the pathology part of it, but now quickly moving to the few intraepidermal disorders which are asked. Now, there are lots of intraepidermal disorders, but two are majorly asked in the exams, and we'll be talking about those. They are pemphigus vulgaris and pemphigus foliaceus. Now, as the name suggests, pemphigus vulgaris. Vulgaris means common, and so obviously it is the commonest form, and so we are discussing first about that. Now, here, the important clues again. Look at these two pictures. These are the two most important clues. If you have a patient with persistent oral erosions, think of pemphigus vulgaris. Now, this is a great cue, because the major immunobullous disorders asked in the exam are pemphigus vulgaris, foliaceus, and bullous pemphigoid. Out of these, it is vulgaris which will present with oral erosions. These oral erosions are painful, persistent, and spreading in nature. So they will keep spreading, and they are seen in 100% cases of pemphigus vulgaris. So pemphigus vulgaris, oral erosions, and then in the skin, you see flaccid bulla. Flaccid bulla which rupture to form erosions. So if these two are present, flaccid bulla and oral erosions, think of pemphigus vulgaris. What is the usual site where you will see them? Pemphigus vulgaris can present anywhere in the body, but my trunk and flexures are common site where I see pemphigus vulgaris lesions being there, right? Moving on to the next category of pemphigus group of disorder, which is asked, which is pemphigus foliaceus. Now, in pemphigus foliaceus, my target antigen is at desmoglein 1, which is present at the level of corneum. So you have a subcorneal split. So if you remember your layers of the skin, the stratum corneum was the topmost. So here the desmoglein is being targeted, which is present in the stratum corneum. So you have a split which is very, very superficial in the skin. So because of that, even if patients form a bulla, that bulla ruptures very, very rapidly. So that when a patient comes to you, you hardly see any bulla, and what you see are just superficial crusted erosions. So you do not see any bulla, but you see superficial crusted erosions, which are present in seborrheic distribution. So what do you mean by seborrheic distribution? They will be present on face, on the upper part of the trunk, so upper chest or upper back. And very, very important, you will have no oral erosions or you will have no mucosal involvement, because in pemphigus foliaceus, desmoglein 1 is targeted. In mucosa, desmoglein 3 compensates for the function of desmoglein 1, and you do not see oral erosions. So if you have superficial crusted erosions in seborrheic distribution with no oral erosions, no mucosal involvement, think of pemphigus foliaceus. Now quickly differentiating between the two, pemphigus vulgaris and foliaceus. So target antigen in pemphigus vulgaris is desmoglein 3. It can also be desmoglein 1. So vulgaris can target both desmoglein 3 and 1, but more importantly, it's desmoglein 3. And if you have to mark 1, please mark desmoglein 3. Then in foliaceus, F for foliaceus, F for first. So my target antigen is desmoglein 1 here. So 1 or first is the target antigen in foliaceus. The split that I see in pemphigus vulgaris is above the basal layer, and so we call it suprabasal split. In foliaceus, we get a subcorneal split. Dr. Preeti would be elaborating on the split and the antigens. Coming to the clinical features, pemphigus vulgaris, I told you, can be present anywhere on the body, but trunk and flexures are important sites, whereas pemphigus foliaceus will present in the seborrheic distribution. In skin, you would see flaccid bulla here, and in mucosa, you would see 100% involvement of mucosa, so there will definitely be a history of erosions. In foliaceus, you just see crusted erosions. You hardly see a bulla here, and you would definitely not see any oral involvement or any mucosal involvement. Now remember, we will discuss about a sign, but since we are enumerating all the differences here, Nikolski sign is positive in both these disorders because they are both intraepidermal disorders. Nikolski sign will be positive in both. So if you remember this table, clinically, you would be able to differentiate between vulgaris and foliaceus. Coming to last clinical sign, which is very, very important here, which I have been mentioning, is the Nikolski sign. So Nikolski sign is always positive in intraepidermal disorders, whereas it is negative in subepidermal disorders. Now, what is Nikolski sign? If you have a patient of pemphigus vulgaris or foliaceus, you would see bulla, you would see erosions. Now, take an area of skin which is around that bulla, around that erosion, and just put a shearing force on that area. Now, because of the antigen-antibody complexes in the skin has become weak in the epidermis, When you do this shearing force, the skin splits off and you notice either a bulla or an erosion forming, which will not happen if you do this normally. Because the skin has become weak, you see this positivity. It would be negative in subepidermal disorders because there the split is quite deep. It's at the dermoepidermal junction, so you are not able to apply that much force, which can split apart the epidermis. So Nikolski sign, remember, is positive in intraepidermal and negative in subepidermal disorders. Right. So here I wind up the clinical features of these two conditions, and Dr. Preeti will now explain you about the histopathology and DIF.
So taking over from here, I think ma'am has beautifully told us about especially the Nikolsky sign, and I think all of you should take a screenshot of that table because it gets you a lot of questions in your exam. And continuing from there, the split that we were talking about. Of course, both of these being pemphigus are intraepidermal, but the level of the split is what will help you clinch the diagnosis in the exam. And that's the buzzword you should be looking out for, or one of these images. So the first thing that we see over here is pemphigus vulgaris. And you can notice whether I say vulgaris or foliaceus, wherever the split of the bulla is definitely in the epidermis, so intraepidermal. But you read so many layers of the epidermis, so where exactly is that occurring? In pemphigus vulgaris, we call it a suprabasal split. So you can notice this is the stratum basal. So the basal layer is standing as it is, and the level of the split has occurred above it. So much so that because, of course, this is the bullous cavity and the bulla that you are talking about, but the basal layer or stratum basal that is standing there is as if it's like a tombstones that you see in the graveyard, and that is exactly why it's called as the row of tombstone appearance. And this definitely reminds me of another tombstone that you study in general pathology, although that has nothing to do with this, but correlating all of that, tombstone appearance is also seen with coagulative necrosis and ghost cells and tombstone, which you study over there, and this is another tombstone for pemphigus vulgaris. Now when I move on to pemphigus foliaceus, again I see the split is in the epidermis, but this time, as ma'am was telling us, that these usually you don't see the bulla because these are going to occur at a subcorneal split. This means this is the stratum corneum and the split has occurred just below it. So only one layer was left above, that is the stratum corneum, which of course gets eroded, and hence you were seeing more of crusting that ma'am was explaining to you a while ago. Now, whether it is pemphigus vulgaris or foliaceus, whenever we are doing a diagnosis, it is just not histopathology or the pink and blue that you see. You also have to do an immunofluorescence, and that is where the talk or the interaction between the dermatologist and the pathologist also happens. So this is something almost like a radiology, that we never give diagnosis in isolation. It is always very important that we get to know what is happening on the clinical side, and then we give a diagnosis of the skin biopsy. And whenever a skin biopsy is sent, like any biopsy, be it breast, prostate, or endometrium, the usual fixative that we want to send it in is going to be formalin. To be very precise, 10% neutral buffered formalin is going to be for all biopsies in pathology. But especially over here, because you're also sending it for immunofluorescence, there is one drawback of sending a biopsy to us in formalin, because formalin tends to shine on its own. What am I trying to do over here? Immunofluorescence, I'm using a fluorescent microscope. I'm using ultraviolet light, that's fluorescent microscope, and formalin, without adding any dye, under ultraviolet light, formalin can show autofluorescence. It tends to shine on its own. So if I've sent for immunofluorescence, I'm obviously not wanting that formalin should shine in that process and interfere with whatever finding I'm trying to see. So I prefer that I send the biopsy in normal saline or any other solution which is not formalin or is not going to shine under the fluorescent microscope. Having said that, now when we are dealing with pemphigus, because all the antigen antibody complexes which ma'am was telling you against desmoglein 3, desmoglein 1, and I think as educators we tend to think so similar, in such a similar fashion, that ma'am just told you foliaceous F for first and desmoglein 1, and that is exactly how I also teach you in the pathology lectures. So whatever desmoglein 3 or 1 is being attacked, those immune complexes or antibodies are getting deposited around these cells, and that is why it gives you a classical fishnet pattern. They are pretty sick of calling it fishnet, and this buzzword has become pretty common. So now they also like to call it the reticular pattern, which you should be knowing for the exam. But this now reminds me of so many fish appearances that you've studied in path, micro, derma, even gynae. I've given you a homework of few of them, although I know there are more that I can enumerate, but then it becomes endless. So we decided that we want you to give us an answer to these 5 fish mouth or fish appearances in different subjects, and we'll be watching out for your answers in the comments. But now, having done that, we've discussed all of pemphigus. I want to continue from here. And before we go on to the clinical, I want to now show you another split so that you can correlate. In this particular disease, which is not pemphigus, as you can clearly see, the entire epidermis has gone above. No layer of the epidermis, no basal layer, no layer is left behind. Another picture of the same. The entire epidermis has been split. So now what I come across is going to be a subepidermal split. And that is what you see in bullous pemphigoid, which we will be discussing next. But look at this very carefully, how would, because usually pink and blue are the pictures which students have a problem with in the exam. In this picture, can you notice that the entire epidermis has gone up, could easily be identified because this brown color layer, brown color is melanin, melanocytes, those are present in the stratum basal, right? And I can see those included have gone up. This means the entire epidermis has eroded, or the bullous has cavity has formed. So subepidermal split is there. And now if I zoom into these, in the cavity, I can see some cells which are not looking like the usual pink and blue, but rather having that slight orange tinge to them. And my hematology knowledge tells me that the orangish cells are always eosinophils. And that is exactly what the bullous cavity is going to show you when we are talking about bullous pemphigoid. So, of course, before we go on to the tense bulla and all the clinical parts of bullous pemphigoid, this is a picture which I want to show you that I have immunofluorescence done side by side. And because ma'am will tell you about those hemidesmosomes and bullous pemphigoid antigen in a while, I can see that the pattern noted over here is a linear immunofluorescence. Now, linear immunofluorescence, I'm not reading for the very first time. Let me first ask you, where else in dermatology do you study about linear immunofluorescence other than bullous pemphigoid? Is a disease called EBA. Although we are not touching, I think, ma'am, we are not discussing this too much in detail because we wanted to make it very crisp and high yielding. But there is another thing called EBA, epidermolysis bullosa acquisita, in which there is a defect in collagen 7, and that can also show you a linear immunofluorescence. But the difference between the two is the level at which the linear immunofluorescence is seen. So if it is seen on the roof of the bullous cavity, and that is the roof over here, you call it bullous pemphigoid. Whereas if the linear pattern is seen at the floor of the bullous cavity, that is more in case of EBA, and that is exactly on the basis of the antigen that is getting affected. In fact, there's a very fun way of learning this also, that in bullous pemphigoid, God is above, and that's what we believe. So the God is above, that is on the roof, and that's where you get the linear immunofluorescence on the roof. And epidermolysis bullosa acquisita, aqua means water, waters of course on the ground. So that is where you get the immunofluorescence over here. But that's just a quick way of memory. The actual concept behind it goes in the antigens that are affected, which we will be discussing in a while. And that is where I'll hand it over to ma'am. But just a quick question before that. This is not where the linear immunofluorescence ends, because somewhere in pathology, in the renal pathology chapter, we read this the same in RPGN type 1, which is also known as the good pasture syndrome, which shows me a linear immunofluorescence. So I think, ma'am, with this, I have discussed the
I think
pemphigus
make
versus
a point here, Dr. Preeti. So you've
Yes.
beautifully elaborated this and it's showing very clearly. So just another question that students get on this is that when we say roof and floor, so what
Yes.
exactly is the roof and floor? So what we do is we put the specimen, as Dr. Preeti said, that the immunofluorescence specimen in a salt solution, and we split our dermoepidermal junction at the level of lamina lucida. So that is
Ma'am,
another question.
saying 1 molar saline that we are talking about?
Yes, yes, absolutely. So we put it in 1 molar NaCl, and this technique is called as salt split techniques because it splits my dermoepidermal junction into two parts. So dermoepidermal junction is this thin layer, and that is why you see this linear immunofluorescence in bullous pemphigoid as well as EBA. But now, how to differentiate different disorders which are there in the epidermis? So we put salt, it splits at the level of lamina lucida. Now, as Dr. Preeti said, with bullous pemphigoid, the antigen is in the hemidesmosome. It is BP antigen 180, 230 that you know. That is above the lamina lucida. And that is why when you split it, you see fluorescence on the roof. Whereas in EBA, the target antigen is collagen 7, which is below the lamina lucida. It is in the anchoring fibrils, it's below the lamina lucida. And that is why you see it on the floor. So immunofluorescence, I believe it's the most beautiful thing. Whenever I used to go to my pathology colleagues, I would tell them that show me some DIF images because this looks really, really beautiful and better than that all blue and pink that we are so used to seeing with
But
pathology.
ma'am, it's only beautiful for you and for me. I'm sure the students do not like immunofluorescence at all because maximum queries that I get regarding doubts are
Oh,
immunofluorescence, not just of dermatology, but also of immunology and other
I'm
topics
sure.
because
Yeah. So
not a
for
topic
us,
which is
it's
loved
mainly
by all.
immunobullous, and so that's why I think
Yeah.
we are restricted and happy.
I mean, I being a pathologist, I have been made to like all of these colors, so I don't have an option. And I think for
Yeah.
you, because this is just one section, we love
One
it. But
section.
students definitely don't, and they're not going to like us for saying that we are loving immunobullous or
But I
immunofluorescence. But
hope we are making
nevertheless,
it easy for them.
I
Yeah.
hope so too. I hope so too. Continuing on the same, I think, ma'am, I'm done with the histopathology and the immunofluorescence of bullous pemphigoid. And since you were describing them, let's get going with the clinical features of BP as well.
Sure. So, coming back to the clinical features now. So, the whole idea of this session is to tell you how we can integrate. If we have the path, we can go back to clinical. If we have the clinical, we can go back to path. So, as we've already shown you what's happening at bullous pemphigoid. So, if you remember our first slide, I talked about intraepidermal and subepidermal disorders. So,
Mm.
intraepidermal, we showed, Dr. Preeti showed you very beautifully that the split was in the epidermis. But what happens if the split is happening at the subepidermal level? So that means there my dermoepidermal junction is being targeted. And dermoepidermal junction, though may seem like a very, very thin layer, it is full of antigens. And you would have, you can go back to our main lectures to know about all those antigens. Here, the purpose is to give you quick answers to the questions which are asked. So when we talk about subepidermal disorders, there is a whole plethora of disorders which come in subepidermal disorders. But there are two main disorders which are asked to you in the exam. One is bullous pemphigoid and the second is dermatitis herpetiformis, which both of which we will be discussing now. So in bullous pemphigoid, the target antigen is at BP 180 and BP 230. And these are located at the level of hemidesmosomes. Hemidesmosomes are directly connecting with the keratinocytes. So this is the first structure in the dermoepidermal junction, which is hemidesmosome. And in that, we have the target antigen, which is BP 180 and BP 230. If these are being targeted by my antibodies, I get a disorder which is called as bullous pemphigoid. So pemphigoid and pemphigus are different. So pemphigus is intraepidermal and pemphigoid is subepidermal. So here the god has become below. So we were just discussing that. So, but yes, so here goid is subepidermal. Remember this. Now, how does it present to you? As I was telling you initially, now here there is a complete roof of epidermis. So I have tense bulla here. But an interesting part about this disorder is that even before the bulla are formed, the eosinophils which Dr. Preeti showed you starts to come and fill up that space. So even before the bulla are formed, these eosinophils lead to formation of urticarial patches in the skin. So typically a patient comes to you with itchy lesions on the body, and when you examine, you see these large urticarial patches. Lot of times you confuse it with urticaria, you give anti-allergics to the patient. But when a patient is not responding, then you think that probably it is the pre-bullous stage of bullous pemphigoid. So bullous pemphigoid has a pre-bullous stage. Before the bulla are being formed, the patient will have itchy urticarial lesions, which can persist. The itching can even persist after the bulla is formed because of the presence of eosinophils. But a lot of time in the question, they can give you this. The patient presents with urticarial itchy lesions and then develops tense bulla. And that again will help you to clinch a diagnosis. So it starts with the pre-bullous stage and then it goes to the bullous stage. And in bulla, now you have tense bulla, which can even be hemorrhagic. There can even be some blood in it. So you get tense hemorrhagic bulla here. What do I mean by tense? So when a bulla is tense, it will not rupture easily. So you have persistent bulla, which is persisting for many, many days. And then when they heal, they leave behind these hemorrhagic crusts. So they heal also with hemorrhagic crusts. Bullous pemphigoid is usually again seen on trunk, which is the commonest site. mucosal involvement is only seen in 30% of cases of bullous pemphigoid. So for all practical purposes, in your exam, examiner will not try to confuse you, and usually I've never seen a question where they want to ask you about bullous pemphigoid and they have given you mucosal lesion. So, or for all practical purposes, as I said initially, mucosal lesion, think of pemphigus vulgaris. So urticarial lesions, stens bullae, healing with hemorrhagic crust, think of bullous pemphigoid, and we've already shown, Dr. Preeti has shown you beautifully how the biopsy would look like. So there will be a subepidermal split. If you do a DIF, you see a linear split, and to differentiate it from EBA, you do a sol split and you see immunofluorescence at the roof of the bulla. So these are some important features which are asked about bullous pemphigoid. Now, before we move on to dermatitis herpetiformis, this is a very good table which can help you differentiate between these two disorders. Pemphigoid group of disorders is usually seen in older age group, so 60 to 80 years. Bulla would always be tense. And then there are certain features which are absent in pemphigoid and present in pemphigus, which we will remember with a very, very common mnemonic, which you all know, called as MINAR. So MINAR, M for mucosal involvement, present in pemphigus. Intraepidermal bulla, present in pemphigus. Nikolski sign will be positive in pemphigus, but not positive in bullous pemphigoid. Then acanthocytes or Zang cell or acantholytic cells will again be seen in pemphigus, because what are acantholytic cells? They are keratinocytes which have been separated because of separation of desmosomes. In bullous pemphigoid, the split is at dermoepidermal junction. No keratinocytes, so no acanthocytes. So acanthocytes again absent here. Row of tombstone, which Dr. Preeti showed you, is present in pemphigus, not in pemphigoid. So if you remember these important clues, you will never have a problem in diagnosing two different set of disorders, which is pemphigus and pemphigoid. Anything you want to add here, Dr. Preeti, before I move on to dermatitis herpetiformis?
No, I think we are pretty much sorted and we've discussed that. Let's move on to the next because we are also going to discuss a few questions after that. But for the students, I think the table that ma'am just showed you, I think that's a very screenshot worthy table, because for your last day revision, it is going to be this that you will get back to when you won't have so much of time to, get back to such a lengthy lecture. This is exactly what you'll revise in your last 1 to 2 minutes before the exam and get going.
Absolutely. So now, as I told you, in subepidermal disorders, we talk about two main disorders. So coming to dermatitis herpetiformis. Now, this is a very unusual kind of subepidermal disorder. The target antigen in dermatitis herpetiformis is not there in the dermoepidermal junction, but still it is clubbed under subepidermal disorders, because we'll see what happens in DIF and all. So in dermatitis herpetiformis, my target antigen is transglutaminase. And this is epidermal transglutaminase, which is targeted. So that is one unusual part about it. The second unusual part is that it is associated with gluten sensitive enteropathies. So typically, the transglutaminase that I'm talking about, there is a cross reaction with the GI and the epidermal one, and so patient has gluten sensitive enteropathy. So typically you will have history like diarrhea, abdominal pain, which would be given to you. Something related to celiac disease would be mentioned in the question. So any of these may be given in the question, and that will tell you that, okay, probably we are talking about dermatitis herpetiformis. The third unusual thing about dermatitis herpetiformis is there are no bullas that you see here. You do not see a bulla in histopathology. You do not see a split. So it is here that this is classified into subepidermal disorders, but this is unusual because of these three features. So how does a patient present to me with dermatitis herpetiformis? Typically, it is the extensors of the body which are involved, elbows, knees, back. These are the areas involved, and the patient will present just with itchy, excoriated papules on these areas. So itchy excoriated papules which are not improving with treatment. Any patient who would come to you with itchy excoriated papules, you would think of eczema, you would think of drug reactions, you'd keep treating the patient, but the patient will not improve and the patient will keep coming back to you. So when you have these itchy excoriated papules with extensors, take history of GI symptoms, and think about dermatitis herpetiformis. So this is how it presents. You see these itchy excoriated papules. You do not see any bulla. You do not see any mucosal involvement here. Just this clinical manifestation is there. And that is where I need my pathologist friend to help me diagnose, because it can only be diagnosed after I do a histopathology. There are some therapeutic interventions which can help in dermatitis herpetiformis, like if suppose a patient cannot do a biopsy, give the patient dapsone and restrict gluten for these patients. Once you do that and the patient starts improving, you think again of dermatitis herpetiformis, which comes to the point that the treatment for DH is giving dapsone and gluten restriction. I specifically mentioned the treatment here because in all the immunobullous disorders, it is only for this condition that it is asked. So, easy for you to remember, D for dermatitis herpetiformis, D for dapsone, and D for diarrhea or abdominal pain. So that helps us to remember what does dermatitis herpetiformis present you with. But always we have to make a definite diagnosis, and that is where Dr. Preeti will help us out.
So exactly with the kind of history that ma'am has just told us, that these will be patients associated with celiac disease or gluten-sensitive enteropathy. I think by now our students already know those are the barley, rye, oat, and wheat, the bro cereals. These are the ones that they will be consuming, and it is the gluten that is present in them, the sensitivity to gluten, or in fact not the entire gluten, but a part of it called alpha-gliadin, which is going to be causing all of this. And the cross-reactivity that ma'am was telling us, why does it particularly happen in these patients? So what is it with celiac disease that links it? Celiac disease patients have HLA DQ2, DQ8 polymorphisms. And in these, because of the gluten, the type of antibodies formed are IgA type of antibodies, like anti-tissue transglutaminase antibodies, anti-endomysial antibodies. They are all of the IgA type. And now the T transglutaminase that ma'am was telling us in the epidermis, the IgA goes and cross-reacts with the same, resulting in dermatitis herpetiformis. And like ma'am told us, these patients are going to be treated with dapsone. So the DDD story is obviously what we've settled over here. There's diarrhea, DH, and dapsone. What I can add as one more D to it is then celiac disease, the most common part of the intestine affected is duodenum. So all these antibodies that are formed are going to go and maximally attack the duodenum. And we know duodenum is a very common site for iron absorption, right? If duodenum is attacked, iron absorption will be a problem. So another feature that can come up in these patients is iron deficiency anemia. Now coming to the main crux of the matter, that is dermatitis herpetiformis. Yes, you can see the epidermis over here also is getting detached. So it is a subepidermal split, an unusual one like ma'am was telling you the exceptions. And you can see a lot of inflammatory infiltrate over here on the dermal papilla. In fact, I know it is not important for you to know this by zooming in, but you should know these are neutrophils, and it's primarily neutrophilic infiltrate that is happening at the dermal papilla. But when I want to confirm it with my immunofluorescence, I can see the same tips being highlighted over here, and that is why this is referred to as the tip lesion. And if I ask you which antibody is getting deposited, without a doubt you will say it is the IgA antibody, and that is the tip lesion which they ask you. So I think if I just had to give you a 4-word final giveaway for Pemphigus vulgaris and foliaceus, it was the Pemphigus vulgaris especially was row of tombstone appearance and suprabasal. Foliaceus was subcorneal. Bullous pemphigoid was of course subepidermal with a lot of eosinophils. Dermatitis herpetiformis is also subepidermal with neutrophils and IgA deposition giving you the tip lesion. You will always get a history of celiac disease, gluten. So ma'am has already told you the treatment. And with that, of course, we have ended our discussion, but we wanted to keep a few MCQs because without solving MCQs, the purpose of this entire lesson is not solved. So ma'am, the first question is clinical, which I would want that you should only take it right away.
Sure. So if you look at the question, the first line itself is giving me the clue. A patient presents with flaccid bullous lesions involving the oral cavity and skin. So as I told you in my first slide, flaccid lesions, oral lesions present in the skin. And now further to help you, we are seeing acantholytic cells on Zhang smear. Acantholytic cells, again I told you Minar. So acanthocytes or acantholytic cells or Zhang cells are an important feature in intraepidermal group of disorder. Intraepidermal, we studied vulgaris and foliaceus. Easy way to differentiate, foliaceus will never have oral mucosal involvement. So here, since there is oral involvement, there are flaccid lesions, there are acantholytic cells, the diagnosis diagnosis becomes very, very straightforward. It is a case of pemphigus vulgaris. Even if you look at the image, you see flaccid blisters which are there. And so there is no confusion. We look at the other options. Foliaceus, oral involvement is not seen. Dermatitis, herpetiformis, you do not see any bulla. We do not see any other history suggestive of dermatitis herpetiformis. And in bullous pemphigoid, the bulla would be typically dense and there will be no acantholytic cells. So I
Perfect,
think
ma'am. So
this
I
is
think
quite.
we've got this sorted, and I'm sure our students by now, we are hoping that after this lecture, they've solved this question as well. Let's take up the next question, ma'am. I think you can get going with this as well.
So now this is a question which tells us that why do we need an integration of dermatology and pathology? So the question is clinical, but the options are something related to DI. So first I'll read the clinical question and then Dr. Preeti can take over. So again, we have a 30-year-old male patient who presents with flaccid bulla on erythematous base, and there are again erosions over the mucous membrane. The blister develop painful erosions which rupture easily. And so, looking at the question, you know there are flaccid lesions, there are oral erosions. We know now that the diagnosis is pemphigus vulgaris. We discussed it in the previous question. But the question here is not about the diagnosis. They are asking you what is the most likely finding on an immunofluorescent examination of skin biopsy of this patient. So, Dr. Preeti, over to you.
So I think our students already know this. Pemphigus is famous for its classical fish net appearance. And like we were discussing, it is IgG deposition that is going to occur. So this becomes the best answer that we will be marking over here. And I hope you did not fall for the trap of others like IgA in dermal papilla. That was the tip lesion which I told you for dermatitis herpetiformis. Then IgG deposition that was occurring, but at the dermoepidermal junction, these we were discussing. Of course, the roof and the floor, we discussed bullous pemphigoid, we discussed EBA. But ma'am, there's one more option written over here that is linear IgA deposition, something which we've not told them specifically, but if you wanted to add a quick line to wrap it up.
So, as I was telling you in subepidermal disorders, that there is a plethora of disorders. There are so many antigens in the dermoepidermal junction that we have a lot of disorders. So, when you have linear IgA deposition, this is a condition called as linear IgA disease. Linear IgA disease in kids, in children, is also called as chronic bullous disease of childhood or CBDC. The characteristic feature that you see in this kind of disorders is you see a string of pearls appearance. So typically you will have blisters which will be present in a string appearance. So string of pearls appearance is classical for that. However, since it's less commonly asked, we did not discuss it, but the important point I've told you here.
Right, and that also reminds me, I have also taught them a string of pearls appearance, but that's in microbiology. When I teach them a bacteria that is Bacillus anthracis, that can show a classical string of pearls appearance on a penicillin agar. That's just to give them those buzzwords. And I think this question is also done, which takes us to the last question over here. Here we have a woman who's presented with pruritic rash on the elbows, the buttocks, with recent diagnosis of gluten sensitivity. So I think the extensor surface is mentioned, the gluten history mentioned. I'm just saving time. And I think, ma'am, I'm saying the right things clinically and highlighting them
Absolutely.
correctly. So on immunofluorescence, further, we have IgA deposition. Everything over here is going in favor of dermatitis herpetiformis, be it the clinical or the immunofluorescence. And that gives me the answer also. And I can see the classical tip lesion and the dermal papilla IgA that is getting highlighted. All the other options we have easily ruled out with our discussion, which smoothly brings us to the end of it. Any closing words, ma'am, on especially for students who have their exams upcoming, the nearest being the INI-CET, anything more or less that they should be targeting? And I think we'll wrap it up after that.
So, since this was more of a clinical session, I would just say that go through the structure of the skin, structure of dermoepidermal junction, and that can help us to sometimes because they ask you the level of the disorder based on the antigen. So, I can do a quick recap here on that. So, I have a quick mnemonic for that. First, we pray, then can eat. So, first is F, foliaceous, V is vulgaris. So first is foliaceous, it is desmoglein 1. V is vulgaris, desmoglein 3. Prey, first we pray. Prey is pemphigoid, and that is mostly bullous pemphigoid that they ask you. And bullous pemphigoid target antigen is 180 and 230. And then can eat. So then it's just like that. can eat is important. So with can, we have cicatricial pemphigoid that they can sometimes ask you. And with eat, I have epidermolysis bullosa acquisita, which we just discussed, has collagen 7. And since it was there at the floor of the bulla, it is the lowermost. So sometimes they ask you this. So I think this is another important point which we can discuss. Otherwise, I think this is a good wrap up of immunobullous disorders, and you should be able to get all your answers correct.
Right. So just wrapping it up, if you want to do a quick 2-minute recap of this session, I think the first table that ma'am showed you as difference between vulgaris and foliaceus would be a screenshot which you will be revising. Second would be the difference between pemphigus and pemphigoid, which is very important, especially the minar mnemonic that ma'am told us. And third, of course, is this. Thereafter, for pathology, you will go through all the images quickly in a minute or two, and that is going to be a summary of the entire topic, which will get you a question, especially in the upcoming exams. So I hope we've simplified it for you. We'll also be looking out for the fish answers, which we asked you in the comments. And if you have any other suggestions for us, especially for dermapath micro integration for the future sessions, you can put those topics in the comments. And I think, ma'am, maybe we can have another session where we can take up a mixed bag of MCQs for them, especially before their exams, which might help them with these topics further.
Absolutely. We'll be waiting for your inputs and we can work accordingly.
Done. Thank you. Thank you so much, ma'am, for all the insights.
Thank
And
you
I'll
so
be
much
meeting
to
you
you
soon
too.
for the next
Yes,
session also.
absolutely. Wonderful session. Thank you.
Bye.